Our speaker for the next session, the next speaker for the same session is Dr. Sai Satish. Dr. Sai Satish is an internationally renowned senior interventional cardiologist from Apollo Hospitals, India. He is also a practicing interventional cardiologist and teaching faculty at one of the world's best TAVI training centers, the Gottstein Institute of Cardiology in Budapest, Hungary. A pioneer in the field of transcatheter valve therapies, he holds the reputation for having performed the highest number of percutaneous H2H mitral repairs in the subcontinent till date. It is time that we welcome Dr. Sai Satish to deliver his presentation. Thank you.
Hi, thank you so much for the generous introduction. First of all, I'd like to say hi to Saibal. He's the father of MitraClip globally, and it's always nice to see him getting a session. Hi, Saibal. Hello to all the other panelists. So I hope you can see my presentation.
Yes.
Okay, so I'm just going to go into presentation. There we go. So there are about 26 million cases of heart failure worldwide, about 37.7 million if you take the undiagnosed cases. We have a 1 in 5 risk of developing heart failure in our life. It's the #1 cause of hospitalization globally, and over 50% of these patients will be re-hospitalized within 6 months of discharge. Several reasons why this is happening: increasing life expectancy, diabetes, hypertension, coronary artery disease. Even in India, we have a staggering 4.6 million cases of heart failure worldwide in India alone. And mitral regurgitation is a significant component, worsening outcomes in these patients. Even in a country like America, about 4 million cases of mitral regurgitation are diagnosed annually, and only 1.5% of them are treated. Now, what is MitraClip? MitraClip is a transcatheter refinement of a surgical procedure called the Alfieri stitch. It's a mechanical solution to a mechanical problem, and the repair creates a tissue bridge, thereby abolishing or reducing drastically the regurgitation. The first in man was in 2003. We have Saibal here, who was part of EXPAND, the highest enroller for COAPT, which established this therapy. So I feel quite embarrassed presenting COAPT data with Saibal as the chair. So just 2 important points. The first thing that COAPT showed was durable reduction in MR, improvement in quality of life in the 24-month follow-up, and it's the first therapy to show longevity for patients as well. EXPAND mimic these results, not just across functional mitral regurgitation, but also degenerative mitral regurgitation. With that, I'm going to jump straight into my cases. I'm going to show you about 3 or 4 cases. I have about 13 minutes left. The first patient I want to discuss with you is an 89-year-old male weighing just 36 kilos, old MI in 2000, large anterior scar, severe early dysfunction, EF less than 20% on GDMT, progressively worsening since 1 year, severe MR since 1 year, 6 hospitalizations in 4 months. Unable to be discharged, this admission was over 45 days in the CCU on and off ventilator. So you can see how horrible the LV is. So you saw how poor the LV function was in those cases, and here is the actual LV function. It's about 13% ejection fraction, torrential MR. The family was spoken to, wide jet. They said, look, all we want is we want him to be able to come home. We just want him to come home. So we said that, look, we can't promise miracles in this case. 13% EF, this was not a COAPT case. This patient had an LV of over 8 centimeters. But the family was very cognizant of the thing and said, go ahead with the case anyway. So went ahead. You can see the device open. You can see the clipper arms coming down beautifully on both the leaflets. A single clip. The MR went from torrential MR to nothing. This is before, this is after. And you can see both LVOT and bicommercial views, almost trace MR. The LA V wave went down significantly, and this was the patient. So to cut a long story short, after almost 45 days of being in ventilator in and out, for the first time, he was off ventilator, he was off all supports, and On day 4, he was finally shifted to the ward. Now you can say, okay, Sai, this is 4 days later. What about longer? How sustainable are these outcomes? So the second patient I have to show you is a 72-year-old male. Again, similar story, EF 25%, PCI in 2005, severe functional mental regurgitation. Came to us with worsening liver enzymes, severe metabolic acidosis, crashing, creatinine 2.4, lactate 9.6. The first air ambulance refused to take him, BP 80 over 50. Look at that LV. Another 15-20% LV, huge non-coaptation gap, almost 1 centimeter, torrential MR. The heart is barely moving. The minute anesthesia was given by a cardiac anesthetist was like, look, Sai, I'm not going to be able to extubate him. Whatever you do here. Plan was to put one clip, reduce the MR by about 60 to 70%, and then see how he does. The minute we put the first clip in, my anesthetist said, I don't know what you're doing, but the heart seems to love it. His systolic blood pressure went up, his pressures came, his LA pressures came down, and he was just ventilating better. So we had put one clip medially, thinking it's easier to put a clip laterally. So after we finished, we went back, took a second clip. You can see one clip in the LB, the other clip up in the LA. And this is how I like to NICE as a cool trick I learned from Saibal. He kind of aligns everything up in the LA, and under fluoro and RAO, once the clip is beautifully aligned, we just go lung down and the whole clip sails medially. So I get it nice and tight to the first clip. That way there's no significant jump in gradient, plus it gives a really good tissue bridge. So we got the second clip in. That was the huge non-coaptation to then later. And severe MR to nothing. LA V wave shot down from almost 85 to 26. On table, pre-anesthesia lactate 9.5, post-anesthesia 1.36, systolic pressure blossomed. He was extubated on table. Over the next 4 days, his creatinine normalized, his liver function normalized. This was 12 hours later, 36 hours later, and 4 weeks later. So you say, okay, doc, that is 4 weeks later. Now what about longer? 80-year-old male, creatinine 2.5, cardiac arrest survivor, severe MR, post multiple hospitalizations, refractory heart failure, surgical turndown. This was all the way back in 2019. I don't know if you remember this case, Saibal. You were here with me in India for this patient. And the entire team here said that MitraClip will not help this patient. We looked at him at about 10:30 in the night and we said, we'll take a shot. He's anyway that sick. We'll give him a chance at the clip therapy. We put one clip in, huge non-coaptation gap, went from torrential MR to nothing. And this is the non-coaptation gap. This is the MR, severe to absolutely no MR. That's the post gradient was just 2. That's the beautiful tissue bridge dog boning you can see. LABA went from 86 down to nothing. This was him at discharge. For the last 4 years, every month he sends me a message saying, good morning, sir. Thank you for this miracle. Every month. And then he sends a message saying what all a clip can do. He was diagnosed with ILD. He was diagnosed with so many other conditions. Everything blossomed. And last year, he actually went and visited his family in San Francisco. And this was him with his children, with his grandchildren. And this is how transformational this therapy is. I know that I have 15 minutes and I've finished only 8 minutes. I can keep going on, but it will only be repeating what I've shown you as to how transformational this case is. So in interest of time, I'm actually going to stop. And these are multiple stories of patients 4 years back. You know, this patient came to me, bedridden, couldn't walk. And everybody thought we were crazy. Why are we doing a MitraClip in a bedridden patient who can't walk? But what had happened is 2 years of repeated hospitalizations. He had forgotten how to walk. We did the clip. This is a son from San Francisco sending me a screen grab saying, this is my dad 1 month later watching television. This was him relearning how to walk. This was him 6 months later. And this is him 4 years later with the family telling, thank you for this beautiful years for the grandchildren with the grandfather. With that, I'm going to stop my presentation. I still have 6 minutes. So if I know the discussion is slated for the end, 30 minutes, but Saibal is here. And he's the chair of the session. I'll let him decide what he wants to do with this extra 6 minutes, whether he wants to go on or whether he wants to discuss. Hi, Saibal, the floor is yours. Good morning.
So I think we should keep all of the discussion to one end, which is actually nice because we have 4 talks. There's also tricuspid. So let's
Okay.
meet. So the next speaker, I think it's me, right?
Yes, it's you.
So I think she should introduce us.
You should, yeah. Why don't you introduce Dr. Carl and then we'll go to the next talk.